Well, hey, it never fails. Someone always asks me, hey, Heather, what about? And honestly, that's where the best conversations begin. I'm Heather Shaw, certified functional nutrition coach and Pilates educator. After walking through my own wellness journey, hello 80-pound weight loss, I now light the path through my program, The Plan, complete with protein-forward recipes, hormone know-how, and a lifestyle for longevity. This is the Exquisite House Pilates and Wellness podcast. Hey Heather, what about? We're diving into all things movement, menopause, metabolism, and more, especially the stuff no one warned us about. I tell it like it is, but always with a wink and a hug. No perfection required, just consistency, curiosity, and better questions, served up with a side of sass. Well, hey, I am so excited to share with you one of my favorite people. This is Robyn Lowry, and she is an amazing pelvic floor specialist. Today on the podcast, we're continuing. This is bonus material for our World Menopause Day kind of symposium. And Robyn is an incredible miracle worker. I say that she cured the world's tightest vagina, which was mine. But we're going to go through and talk about the phenomenon of what happens through menopause with our pelvic floor. So, Robyn, before we start that, will you please tell a little bit about you and how you got into this and why this is your passion? And then we're going to go into all our questions about all things pelvic floor.
Absolutely. Well, a little history on me. I graduated from physical therapy school at VCU MCV in 1996. I was an orthopedic specialist for about 10 years and treating a lot of hips, a lot of backs, a lot of knees, and I was getting tailbone pain patients, and I did not know what to do with them. So my mentor at the time said, you should take a pelvic health course and see how you do with that. And I took my first course and absolutely fell in love with it, realized there's this huge population of patients that need help. And I've been doing that ever since. So I've been doing this over 20 years, treating pelvic disorders as a physical therapist. Pelvic health physical therapy is a subset of physical therapy. So not every physical therapist can treat pelvic health disorders. There's quite a bit of training involved, certification. It took me several years to get my certification. So I've been doing it over 20 years and really enjoy it. I'm glad I got to meet you in the process.
We have had so much fun. So, talk about a little bit of what happens with the pelvic floor during menopause. Tell us a little bit about that phenomenon and what happens when we lose those sex hormones, and tell a little bit. Just tell us all that, because that's the good stuff.
That's the good stuff. So as a physical therapist, I'm thinking about the mechanical effects, of course, on what is happening to the pelvic floor. And maybe we should start with what the pelvic floor is. Do you think we should start there?
Yes.
Okay.
Tell us about the pelvic floor. We have AIDS. Oh my gosh, this is my favorite thing.
All right. So the pelvic floor is a set of muscles inside the pelvic ring. It's a set of muscles inside of here. It's like layers of hammocks that are suspended inside the pelvic ring. And they serve many purposes. And we can say all the words here.
We can say all the words.
Here we go. So they help to hold in poop and pee. They have a sexual function, and they have an orthopedic function. So when things go wrong with the balance of the pelvic floor muscles, how well they are contracting, how well they are relaxing, how they are coordinating, you can get dysfunction in many different systems involved from the front to the back. So a pelvic floor in this model is very intricate. There are 3 layers to the pelvic floor. There's an external layer that's just underneath the skin, and then there's internal layers 2 and 3 that are inside. And we can access these layers and we can work with these muscles. So when we talk about the pelvic floor, this is the area that we're referencing. What happens in menopause with the change in hormones, especially with a decline in estrogen, is that we can have changes that occur that change the length-tension relationship of the muscle and how well those muscles function. There is something called the genitourinary syndrome of menopause, and it affects everything from front to back. So we have estrogen receptors all the way from the clitoris all the way back to the anus, back to the attachment to the tailbone, into the vaginal canal, and into the labia as well. And so all of these tissues will change and result of decreased estrogen levels as part of the genitourinary syndrome of menopause.
Yeah. So in talking about, and the acronym for that is GSM, because that's a whole mouthful of stuff that I don't know. I haven't had lunch yet. It's like a lot. But in that kind of GSM, we hear a lot about pelvic floor dysfunction, but not everyone knows the signs. So what signs are we looking for in that?
Right. Yeah, so I think when we think about menopause, what sort of commonly pops to mind is vaginal dryness, maybe pain with intercourse, but there's a lot more to it. Within the pelvic floor, or within the pelvis itself, there's a lot of systems. We have our urinary system, we have our bowel system, we have our reproductive system, we have muscles, nerves, lymphatics, and vascular system.
Wow.
Yeah, so there's a lot going on. And as you know, our hormones affect every cell in our body, from all the way up, all the way down, head to toe. And so we can have changes in any of those systems in this area, which then can manifest different symptoms. So when we're thinking about GUSM specifically, a lot of times what patients will initially complain about is maybe vaginal dryness and pain with intercourse.
Yeah.
We also know that within GUSM is changes in our ability to control our urine. So women may start leaking around menopause. Even if they had difficult deliveries early on, they had some perineal tearing, they did well with it. With those hormone changes, they then get changes in the connective tissue that makes it difficult to hold that urine.
Yeah.
So we'll see that. We'll also see increase in bladder function. So in terms of how well it's talking to you. And so a lot of times we'll see increased urgency and frequency and more nighttime trips to the bathroom. Constipation is another one. We don't think about that as
Really?
a sign of menopause. Yes. Struggling with clearing the rectum. If you have any prolapse, especially on the rectal side, you may have kind of hung in there for a while, and then once those hormone changes hit, we're losing some of that tension in that rectum, and it can make it more difficult to pass stool. So we see constipation rates go up with menopause.
And then when we're talking about the clearing, because we talked about this during our sessions, there is more than one space that all of that waste comes from. So talk a little bit about that, because there's an internal sphincter and an external sphincter.
Yeah. So the mechanics of pooping are pretty complicated, and we learn this skill at age 3, and then we don't think about it. But and people are pretty fascinated by this. It's interesting. So coming back to the pelvic model, back to layer 1. Here is the opening around the anus, and there's 2 muscles, the internal and external anal sphincter. And a lot of people think that this is it. This is the only thing that holds in poop and gas, right? These 2 muscles are only responsible for 25% of our fecal continence. So they're not our powerhouse.
Wow.
Deep inside, up above the 2 muscles, is another muscle in here called the puborectalis muscle, and it is our powerhouse. It's responsible for 75% of our fecal continence. And so I think what we were talking about is the intricate coordination that needs to happen between the puborectalis and the internal and external anal sphincter, so that we can tighten when we need to, but also relax when we need to, so that we can clear our rectum and feel like we're nice and empty. And sometimes women struggle with that, especially with the hormone changes on these muscles with menopause.
So then our diet also will impact that, which we'll talk about.
I hear you have someone good coming, yes.
That would be me.
Yeah, great.
So then, is it ever too late to improve that pelvic floor?
No. Menopause changes our hormones, but does not change our ability to heal.
Okay.
Yeah. So studies are very clear on that. When I work with patients, most of my patients are in the perimenopause or menopause age. That's when they're starting to struggle, and they come in, and the outcomes for pelvic health physical therapy are very good. I see it in the clinic, but also it's supported in the literature. It's one of the reasons why I love doing it. It's fun to do a job that's successful. But no, there is no age limit. And so sometimes I'll get a client and they'll say, I need my mom to come in, and she's much older, and so we'll talk about that as well. They can be successful at any age.
I love that. And what are some of the things that we can do as women now? So on our own, before we have to come see you, give us some of those tips and tricks of like homework things. I mean, I know I have my homework. I do my homework, but.
So the biggest thing is sort of shedding away the misconception that we have to grin and bear it. Our culture in this society lends itself to, if I leak urine when I cough or sneeze, that's just the way it is. That I had a baby, or I'm in menopause, and my mom leaked, and my grandmother leaked, and my friends all laugh about it. It's very common, but it's not normal, and it is very treatable.
Okay.
So I think one of the first things is to change your mindset about it and realize that there are things that can be done that are non-surgical and conservative and actually quite effective in improving how well that you're managing your bladder.
So I'm thinking about like when we worked together, there was the concept of like rolling up a towel and sitting on a towel. So I am like my mother. I have this little makeup table in my house, and I take my shower, do my hair, and then I sit down and do my makeup. And so I took a towel and I put it perpendicular on the seat, and then I sit on that towel. And that exercise of sitting on that and having a little bit of pressure on that pelvic floor helped relax things, because my pelvic floor was what we call hypertonic, or very tight. And then there is also the hypotonic. So can we go a little bit into those two things?
Yeah, no, that's an excellent point. Because it is a misconception that if you're leaking urine or you're having pelvic floor dysfunction, that you need to Kegel. And folks will go online, they'll look up Kegel exercises, and they'll start Kegeling, and they'll come into my office and say, I've been Kegeling for months, it's not helping at all. And that might be because they are actually too tight. Yeah, so some of my patients, when I examine them and I take their history, try to understand what's going on, some of my patients really are weak, and they do need to strengthen. They need to improve the strength of the pelvic floor. But some of my patients are actually too tight. They're holding, we call them high and tight. And they actually need to relax the pelvic floor. So I explain to patients all the time that the pelvic floor muscles do need to be strong, but they also need to be dynamic.
Yeah.
And your pelvic floor almost acts like a trampoline. It needs to bulge and relax and then return the energy as you move through your day. So when you get up out of your chair, when you're doing Pilates, when you're coughing and sneezing, that pelvic floor needs to be able to lift and respond to that. And if you're already there, you can't respond very well. So sometimes leaking is related to weakness, and then sometimes it's related to hypertonic, over-tight pelvic floors. So that's the category you fell into.
Yeah, and then tell us about the hypotonic.
So these are patients who truly have muscle weakness, and they need to do Kegels, they need to strengthen, and so I'll make sure that they're doing that correctly. So the breathing with the pelvic floor exercises is really important. And if I wanted to share one tip, a practical tip is when you do a Kegel, you want to make sure that you exhale.
Oh, with the Kegel? Oh, okay. Yeah. Tell me more about that.
Yeah. So what that does is it helps to lift the diaphragm along with the pelvic floor. And you know this very
I knew
well.
that. That's why I asked you. Yep.
Yeah. A lot of patients, when they come in the door and I'll say, let me see you do a Kegel, and they'll go like this. And they're squeezing. And so what they're doing is a Valsalva. They are actually holding their breath, pushing their diaphragm down, locking it in place, and then now they're fighting against themselves to lift that pelvic floor. So they'll say, oh, I've been doing that for months, no wonder it wasn't working. And so the simple act of teaching that patient to exhale when they squeeze makes that Kegel much more effective. And it's really the proper way. It's how our body's supposed to move anyway. So patients who do need strengthening, I work with them a lot on how to properly Kegel and make sure they're doing that correctly.
I love that. So, and I have been saying I love that all through this podcast. I actually do really appreciate what we're talking about, because I think about the space where there is so much misunderstanding, and we talk about like the that funny little chair that people can sit on. Yes, I know it's your favorite thing, which is why I brought it up.
Okay.
So there's a product that is supposed to put in some sort of electronic.
You're probably talking about the Emsella chair.
Yes. So tell us more about that.
Well, if it's too good to be true, it probably is. The Emsella chair, it is supposed to, and I've actually sat on one.
Yes.
I was very curious about it. I wanted to experience, had a lot of patients asking me about it. And so I did try one at a clinic so I could feel it for myself. And what it does is it artificially contracts your pelvic floor. So the idea is you sit in this chair and they turn on this electromagnetic field that actually causes because our muscles are electric, it actually causes a passive contraction. It's supposed to cause a passive contraction of your pelvic floor. So you sit there and you can read a book and whatever, and you sit there and they'll change it up a little bit. They'll change the frequency and the beat, and then you go home and you're supposed to notice an improvement. The problem with that is it's passive. In order to strengthen the pelvic floor, you also need to work on your coordination, the brain connection to the pelvic floor. It is so much more effective if you do the exercise yourself. Right? If your patient or your clients don't come in here in the studio and just lay there and have them have their body passively move, right? If they did, they wouldn't get anywhere.
Right.
Yes, you're teaching them how to breathe, how to move, how to coordinate. You're reestablishing that neural connection with that pelvic floor so that when they go out in the world and they function, they feel better. They function better.
So then with that in mind, our pelvic floor is not a parasympathetic system. It's an active system.
It's active. It's a very active system, yes. And so when we think about what that chair is doing, when you artificially stimulate a muscle, it's only the type 1 muscle fibers. It's only about half of the muscle fibers, just grossly speaking. And so it's so much better if you do those activities actively.
Okay.
Like if you lay down and had someone do that,
you wouldn't do a whole lot. Right.
So what I tell patients when they come in, I'll say, you don't see these in gynecology office. You don't see these in our teaching centers, in our real you just don't. You'll see it in med spas. You'll see it in other places that are sort of entrepreneurial, to be honest with you. Yeah. And the studies are actually not great on the Emsella chair.
Tell me more about that, because I love the data.
Right. I can't call the numbers right off the top of my head, but we talk about the Emsella chair in our pelvic health circles. And we've looked at it like, gosh, should we be putting these in our clinic? Wouldn't this be an easy thing to do? Boy, what a moneymaker. And truly, the studies are not good in terms of long-term results.
Okay.
Short-term or long-term results, they're not great. So, I think maybe a little more studies need to be done on it, a little more development. On paper it looks great, but in function it just doesn't. It doesn't hold its weight.
And then tell us about, because you and I have talked about, like with overactive bladder, there is a study and a treatment with a TENS unit to impact that, and there's a nerve that's kind of around the ankle. Then you set the TENS unit to a certain point. So tell us more about that, because I know that does have a study that shows some effectiveness.
Yeah. That's called TTNS, transcutaneous tibial nerve stimulation. And what you're doing with that is using a TENS unit on a really specific setting. So you can't just go grab your TENS unit out of the drawer and slap it on. You have to have it adjusted to some very particular parameters. But what you're doing is you're stimulating the tibial nerve, which is loaded with parasympathetic nervous system fibers. And that, when you increase parasympathetic drive, you calm the bladder. So that particular treatment is good for overactive bladder. So my ladies who come in and feel like their bladder's talking to them all the time, they feel like they need to pee, they just went to the bathroom and they need to pee again, or they're having trouble sleeping at night because they're having to get up so many times at night because their bladder's talking to them. The TTNS treatment can be very effective in calming that bladder down. The protocol is about 3 months, so it's easy to do. You put it on, you run it for about 30 minutes most days of the week, and then the protocol is about 12 weeks. So it's such an easy thing to do.
Yeah.
Patients tolerate it well, and I've had some success with it in the clinic.
And then tell me, how would someone be able to determine whether or not that urgency is based on overactive bladder or it's based on some loss of hormone? I mean, we're in this like very deep water here. Talk a little bit more about how that's determined.
It's usually a combo platter.
Okay.
Yeah, it's usually all the above, just different ratios of how much each thing is contributing to the problem. So, when we think about overactive bladder, we think about, I talk to patients about what are they ingesting? Are they taking in a lot of bladder irritants? Are you going to Starbucks? And, are you having lemonade? Are you, the 4 big C's, caffeine, carbonation, citrus, and cocktails or alcohol. Those are bladder irritants. So we can help patients with overactive bladder with a lot of behavioral changes. What are you consuming? Are you also getting enough water?
Okay.
We know that concentrated urine acts like a bladder irritant. So when people are not drinking enough water and their urine's more concentrated, ironically that irritates the mucosa of the bladder, which can create overactive bladder symptoms. So those are like practical things that we can do that are conservative, non-surgical, non-medication, just some strategies we can put in place, and sometimes that is enough to take care of the overactive bladder. The hormone changes cause the bladder and some of the support structure around the bladder to weaken a little bit. And so women will feel like their bladder's talking to them more. So sometimes doing pelvic floor strengthening or pelvic floor down training, depending on how they're presenting, can also help with overactive bladder. A lot of my high and tight patients that have tight pelvic floors feel like they have to pee all the time. And so we do a lot of down training, relaxation to get that pelvic floor to let go, and lo and behold, that OAB goes away. And then there's a autoimmune that impacts the bladder. Talk a little bit about that. I don't want to say the word wrong. That's so I think what you're talking about is interstitial cystitis. Yes. So the bladder itself has a mucosal lining similar to the inside of your nose. It's sensitive. And some people who have overactive immune systems, their immune system will go after the bladder. And so they'll get almost like ulcerations in the stomach. They'll get erosions or irritation in the lining of the bladder, which then makes them feel like they have a bladder infection. They'll have high frequency. They feel like they pee all the time, high urgency. Instead of a normal build to urinary urgency, they immediately feel like they have to go to the bathroom. And then sometimes pelvic pain. And so interstitial cystitis, it is a hard word to say, it's complicated to treat. As a physical therapist, I can help with some of the aspects of that. So if a patient has interstitial cystitis and they're guarding, they have a lot of pain related to that, and they're high and tight in their pelvic floor, that's where I could plug in to help them to relax and reduce some of the sequelae of that. Can't cure the IC.
Right.
I have some tips. There's some dietary things that can be done. Working with your doctor on medications with that. that can be helpful. But that gripping and holding that tends to come from the pain and just the agitation, I can definitely help with that from a physical therapy standpoint.
I love that. That's this is the bigger conversation that I think as women, we don't know.
Right.
We don't realize that there's all of this stuff happening in the pelvic floor, bladder, all of those things, that there's so many little muscles down there. I mean, for me, because I've had to have some training in anatomy, I definitely don't have the depth and breadth that you do. I'm really glad, because my eyes would cross. But, there's just a place of kind of naivete, if you will, of not understanding. And then because menopause hasn't been talked about as much in the last 20 years because of, the lack of treatment that we've had following the Women's Health Initiative, and now we're finally coming back into that space, I feel like this is such an important place to talk about. And I don't want this to be taboo because, it's kind of like we joke in the studio that I came and saw you because I had the world's tightest vagina, which I really felt like I did. But the reality was I was right that it was tight, but we also recognized that once we kind of gave it a little yoga session, it was like, oh, thank God, you finally got me in the right spot. Right. And I don't have those same issues, but we also really had to have conversations about what my symptoms were. We talked through a lot of those things to be able to kind of ascertain where we needed to find that treatment, and then physical exam and all of that stuff, which, I mean, we've all had a physical exam at some point in time. This is just a little more friendly in the sense of I felt like you did such a great job at making me feel comfortable. And as someone who has had bad things happen to me in my life where I'm a little more guarded when I'm exposed and vulnerable, it was a wonderful space to be in. So can you talk a little bit about how you approach exam and evaluation, and then where kind of there's an art to what you do? So help me with that. Help me paint the picture of what you do.
So I think, starting with, if I'm speaking to the public about and advocating for pelvic health, physical therapy, really emphasizing that you want to make sure you pick the right practitioner. Not every physical therapist can treat pelvic health, so making sure they have those credentials. The gold standard for pelvic health, and I think why we were able to be so successful, is that we had a full hour. And you don't find that everywhere. And I came out of a setting where I didn't have that, and it was a struggle. But really the gold standard is 60 minutes one-on-one with the physical therapist. I think some patients, when they hear, oh, let's go to physical therapy for my pelvic floor, my vagina, they think back to maybe physical therapy they had in the past for their ankle or their shoulder. It's an open gym setting. Their therapist is managing maybe 2 or 3 patients at one time. It's a very orthopedic approach, and that's not at all what pelvic health PT is like. You and I, we were in a private treatment room, and we had the time to talk about it. We had the time to talk about what was going on, to really understand you as a whole person, even your life experiences that you have that could be impacting. If there is trauma, a lot of times there is a high and tight pelvic floor. That's our body's natural protective mechanism. So I was really glad to have that time to be able to understand that about you, so I could approach you correctly, and we could go after that in the right way. So I would say, when you're looking for a pelvic health physical therapist, look for that full hour, because you really do need it. I can't walk in the door and just put my hands on you. Like if you were an ankle, I could go for it. But that rapport, that trust needs to be built. And then I really want to understand what's going on, so I know how to approach it. And then ultimately, it makes the entire process more efficient. If I understand you better, then we're not running into roadblocks. We can actually get through your case faster if I have that longer period of time each session. So I think that was part of our success, is that it was just the right setting.
Yeah, I think so too. There's a lot of embarrassment, avoidance. I mean, obviously, I'm a pretty open book. I don't share my whole dirt out on the street and pour everything out, but I also feel like some of these places that we're going into are so important. So, and I think we're kind of touching on that, but we can go a little bit deeper and just kind of explaining, why shouldn't we be embarrassed to
Right.
have a pelvic floor person up in our hoo-ha and kind
Yes.
of understanding what's going on down there?
So some patients walk in the door and maybe their doctor told them they're sent by their GYN or their urogynecologist, and they've been prepped. Hey, you're gonna have a pelvic exam, a vaginal exam, or rectal, either way. And so they're ready for it. They're mentally prepared. And then some patients come in and they're telling me what's wrong, and they're saying things like, I have no idea how you're going to help me. I didn't even know you could do this. And so sometimes on that first visit, we won't do a pelvic exam because I really want to explain. I bring out the models. I explain everything, what we're looking at. I really want my patient to understand the rationale behind everything that I do.
Yeah.
And that's not just me. That's how we're trained to do it.
Good.
And so any pelvic PT is going to do that with you. So don't go in feeling like, oh gosh, a lot of my patients tell me they're nervous on the first visit, and I understand that, but I really try to tamp that down so that they understand what to expect and they're not feeling anxiety about what's going on. The other thing too is I have just found, I don't know, pelvic PT is kind of a club, it's kind of a sorority. I will say it's a cool club to be in. And we are, I don't know, I think as a group, if you go into this area of practice, we're very compassionate. Mm-hmm. We're very passionate about what we do, and just some of the nicest people you'll meet. So, I've never met a bad pelvic PT.
I love that.
I go to conferences where we're all
I love that.
kind of cut from the same cloth.
That's how it's supposed to be.
Yeah.
And if you could shout out one truth about pelvic floor health, like something that is a real misnomer that is in our culture or in our society. I think about people who say, oh no, I don't need that. I just need a Kegel. I think that's a big one.
Yeah.
But there's got to be other stuff that, because this is what you do full time and you're not a part-time pelvic floor PT, this is really your calling.
Right.
Is there anything else that you see that's common and you're like, oh gosh?
Yeah. Oh, there's so many. I mean, it is women's health.
Yes.
So there's a lot of things that could be corrected. I think if I had one thing to say, it's that you do not have to suffer with this. If you are struggling with pain with intercourse, if you're struggling with leaking urine, constipation, pelvic pain, it is not a normal part of aging. It's not something that you have to endure. It is common, so people think that it is a normal part of aging and something they have to endure, but you don't. You don't have to put up with it. And there are conservative, non-surgical ways to manage these problems that are safe and easy to do. So that would be the big thing, is you don't have to suffer. That would be the big thing. And the other thing too is, speak up. So speak up, ask your doctor. If you have a physician, you go see a physician and you're complaining about some of the symptoms of menopause, or the genitourinary symptoms of menopause, and they're like, well, yeah, that's menopause, and they sort of don't take it seriously or don't offer you solutions, then keep advocating. And if they still don't provide, find another practitioner. Our grandmothers kind of put up with a lot more than they needed to, but I think our generation is like, oh, we don't have to put up with that. And there are strategies, there are things that can be done to make your life and your quality of life better.
Yeah. Talk about the symptoms that. So we've talked a little bit about hypotonic, we've talked about hypertonic, we've talked about OAB or urgency. What are some of the symptoms in menopause that women should be looking at as these, oh, I need to go see Robyn?
Okay, yeah. Excellent. Well, as you know, menopause affects head to toe.
Yep.
So we could go head to toe with that. But what I would say is anybody who's leaking. So leaking urine is the most common diagnosis that gets women in the door for me. But when I have them in front of me, I start asking them about the other systems involved. So are you leaking urine? Can you cough, sneeze, laugh, lift without leaking urine? the answer should be yes. You should be able to do all those things without leaking. When you get the urge to go to the bathroom, can you delay? And I don't mean hours. I mean, can you delay 10, 15 minutes? Are you all of a sudden slammed with this urgency? And does that urgency come very frequently through your day? Urinary urge should hit about every 2 to 4 hours. So if you're getting up and going to the bathroom every 45 minutes, every hour, something is going on and that needs to be addressed. If you're also getting urge and that causes you to leak, so you get the urge to go and you cannot make it to the bathroom in time, the bladder just opens up, that needs to be treated. So from a bladder perspective, any bladder pain,
Okay.
yeah. And then kind of moving back into the pelvic floor, as we touched on before, constipation. A lot of my women, they'll come in the door with urinary symptoms and I'll start asking about constipation and they'll say, yeah, I feel like I never can clear my rectum very well. Like I'm always backed up, I'm bloated, I'm having constipation, I'm trying to take fiber or Miralax, they're trying to figure out what they can do. When actually the problem is mechanical in the pelvic floor, they're not relaxing very well. And so that constipation can be treated by pelvic floor physical therapy. So I would ask for help that way. Pain with intercourse.
Yeah.
Yeah. There should never be pain with intercourse. And so you'd be surprised at how many women come in the door with urinary symptoms. I start asking them, are you having pain with intercourse? Oh yeah, I've always had pain. I just either grin and bear it, or once it gets going, it doesn't hurt so bad. But that, has a psychological impact and you don't have to hurt. And so that's a very treatable thing as well. So
Love that.
Yep. Hip pain, back pain, I also treat orthopedics. A lot of my patients come in the door with urinary symptoms and they'll say, oh yeah, I've had this back pain for a while. And it's all connected.
Yes, yes. So in that, what you're talking about is the fact that the all those muscles have to they attach to bones.
Right.
And so, like, if someone has an SI dysfunction or they have some, back injury, that's potentially can impact the pelvic floor.
Yes. Sometimes we will see pelvic floor dysfunction as a result of orthopedic injury. So, a common scenario I'll see is after a hip replacement.
Oh, wow.
They've gone in there, the hip, because it's all so closely related to the pelvic floor muscles. Like we said, they hold in poop and pee, but they are also orthopedic in nature. So this layer of muscles here, they are hip rotators. So
that's right.
Yeah. And so if these muscles are not working well, there's an overflow effect into the pelvic floor. So I'm often treating both pelvic floor dysfunction, urinary symptoms, and orthopedic symptoms because it's all connected. It all comes in together. And sometimes we can't clear up the pelvic health problem unless we address the hip pain or the back pain.
Yeah. Amazing. So this was a lot to digest, all of this. We could go deeper. We could go for 2 hours.
Yeah.
But I want to talk to you now about you. Now tell me why this is such a passion for you.
Yeah.
Tell me how this became the calling in that space of I know you were doing this at the beginning. We talked a little bit about you started in just a regular PT.
Right.
And then you were like, no, I want to go deeper. But why did you want to go deeper? What changed for you?
Yeah. I think part of it was at the time I was also starting my own family, and so I had a personal interest, which often drives people. I also suffered some pelvic injury myself. My second child was 10 and a half pounds, born sunny side up. And so he's great. Everybody was great. But I got to personally experience. And so having that perspective, I feel like helps me connect with patients. I understand what they're going through. When they say, I have this or I have that, I get it. I understand. So just having that insight helps. But yeah, I'm very passionate about helping women, and it is an area of practice that's still underrepresented. I'm on all these Facebook discussion groups with pelvic PTs all over the country, all over the world, and there are still large parts of the country that have no access. There's no access to pelvic health. So towns that have no pelvic health therapist, or maybe they're a couple hours away. And so some people are trying to do things virtually to help those patients, but it's an area that needs to grow still.
Yeah.
And then the other thing that really drives me is the outcomes are really good. When you work in an area of practice where the outcomes are good both in the literature and in clinical practice, it's just very rewarding. So it's fun to work in this area of practice because it actually works.
I love that. For me, I feel like that's the thing that I love is it's not an instant gratification, but it's very much a thing of, okay, I know what I need to apply here. And then as we start to do that work with that client, then we start to see that improvement. And I mean, for me, it's the stories of, someone walks in with a cane and then they can walk without the cane.
Exactly.
And for you, it's, painful intercourse, and then they're like, I'm good. I don't have any problems.
The favorite email that I get is, guess what we did last night? And then my next favorite email is, I achieved my goal of, pregnancy. That's a really fun one to get as well. And every once in a while, I'll get flowers from the partner, and that's really fun.
I love that. And we've been focusing on pelvic floor health with menopause because that's kind of where this podcast is focused right now. But you're also touching on the fact that sometimes that pelvic health is either postpartum or there's just some overall dysfunction as a woman that maybe there's a little just help that we need. So can you touch a little bit on that?
Absolutely. In other countries, in Europe, in France, in Spain, in Israel, and Australia, it is standard of care for women to go to a pelvic physical therapist or physiotherapist, as they call us over there, postpartum. And so if the baby comes vaginally or through C-section, those women have a standing order for physical therapy. They've been doing it, and they've been doing it long enough in Australia that we have some really good long-term outcomes and long-term studies. So the rates of incontinence and pelvic organ prolapse and pelvic pain, even low back pain, hip pain, even the number of falls, because incontinence is very closely tied to falls in the elderly.
Okay.
So fracture.
We need to sidebar. I'm like, how much time do we have?
Yeah. So when you can introduce this and really treat women well postpartum, then you're helping them many, many years down the road. We can see that now because those countries do that. And right before COVID, the American College of Obstetricians and Gynecologists, ACOG, came out with a position statement. They said, we are not treating women like we should. That 6-week postpartum appointment is not enough. We need to be doing more based on some of these models out of Europe.
Wow.
And then COVID hit. But that's what we're pushing toward.
Good.
And, you intervene there, but it has the results and it really, can help decrease dysfunction as you get into menopause and later.
Yeah. And I feel like what you're talking about kind of ties back to, we had an interview with Dr. Erin Adams, and we were talking about that our mother's generation, so the generation that did not get HRT because of the Women's Health Initiative, they have really suffered so that there's, spaces where they're going septic because they've had a UTI or they've had recurrent UTIs and they don't understand that they can do some pelvic floor therapy and or maybe it is that interstitial cystitis. Ooh, did I say that out loud? And so they're able to start to look at the dietary changes, or they didn't exercise because their generation was so focused on thinness, and so the overall appearance of strength and fitness and health was really about your dress size rather than the amount of muscle that you had on your body, and so that lack of conditioning can impact. So I'm really glad to hear that the studies are now showing that doing the work fixes the issues that we can have and also works as a preventative. It's the same kind of thing we've seen with HRT, where now the studies that are finally coming out post that 2002 study we're starting to see there is efficacy in HRT. There is absolute reason to use we didn't even talk about vaginal estrogen. Oh my gosh. We have, that is a whole other thing.
It should come in the mail on your 40th birthday.
Thank you.
That's it. Everybody should be on it. It's a wonderful thing.
And quickly touch on that. So vaginal estrogen is something that they're understanding now can be applied. It does not absorb into the system from the standpoint of like
systemic.
Yes, it's not systemic,
right.
but it's that topical impact. And so
Yes.
that is relubricating. It's kind of giving all of the fluff back to things.
The fluff, yeah, it's perfect. We talked about the genitourinary syndrome of menopause that occurs as estrogen declines. We have estrogen receptors all the way from the clitoris all the way back past the anus into the labia, into the vaginal walls, and those estrogen receptors are active your entire life. So when you're not producing it as you were, we see tissue quality changes. The labia gets smaller, the vaginal walls get thinner, the support structures thin out, and then the tissue, especially the vaginal walls, can become less resilient.
Yeah.
And so sometimes we'll see decrease in lubrication, and we'll also see pain with intercourse. Vaginal estrogen cream was originally prescribed when women would walk in the door complaining of pain with intercourse. Like, oh, okay, we need to thicken up those walls a little bit. Let's get you lubricating a little bit better. And what we started to see were some really cool side effects. That urinary control got better.
Yes.
That even hemorrhoids were less uncomfortable.
Okay.
That the vaginal tissue quality improved. That you could have more stability around the urethra. You're bulking the tissue around the urethra, so leaking improved. And then sexual function improves if you get it up around the clitoris. So I will often encourage women to ask their physician about vaginal estrogen cream, not the tablet,
right,
but the cream. And the correct way to do it is to actually put it on your finger, get it in there, and what comes out once you kind of swipe it in, you don't have to get it up near your cervix, just kind of get it up in there. There's a little residual left on your finger, and then swipe it around those other structures. Start in the front and work back.
Yeah.
Get it up around the urethra, around the clitoris, bring it down around the perineum and across the anus, and those tissues will respond.
Right.
Yeah, they will respond. So the safety profile for vaginal estrogen is also excellent. You will not find a single doctor who will tell you it's 100% safe,
right,
because they just cannot do that. But the safety profile is excellent. I have some patients that walk in the door from oncology, and they are on vaginal estrogen cream.
Right.
Their oncologist gives it to them.
Right.
So don't be afraid of vaginal estrogen cream. Take advantage of it. Yeah.
I mean, my takeaway is that when you told me how to put it on, because I had already been prescribed it,
Right.
I was like, excuse me, this is amazing. This is a game changer, because I was kind of in the dark, and I feel like now my body is happy.
Yeah.
It's very fluffy. It's like, thank you.
Good.
And every time I do my application, I always think of you, because I think about how you told me to put it on, and I'm like, okay, we got this.
Front to back.
Yes, and it works. And I cannot begin to thank you enough. Like, I'm actually getting emotional talking to you, because this has changed.
Yeah.
I am getting emotional. This has changed my confidence as a woman. I think we get so invisible as we start to get older, and we shrink, and we don't need to do that. And so I'm so grateful that we've been able to have this time to be able to just share the benefit of what this treatment is, and what it looks like to sit in front of a really amazing pelvic floor specialist who has a passion for making women feel good. And so with that in mind, how do people get in touch with you?
Thank you. So I was so pleased to work with you. You did everything you said. I always say great patients make great outcomes. And that's exactly why I do it. That's exactly why I do it. It's so rewarding. So I'm local here in Midlothian, Virginia, at Prosper Physical Therapy. It's a small clinic. There's just 3 of us in there. I'm the only pelvic floor physical therapist. You do not need a doctor's referral to see a pelvic PT.
Okay,
which is
that's good to know.
That's one less step you don't have to take. So in the state of Virginia, I have direct access. If you call my clinic, you can come make an appointment, come right in. I do communicate with your doctor if you want me to. So
okay, good.
I'll send my evaluation, my report, follow up, whatever that physician needs, if you want me to do that. So I'll send it to your GYN or your gynecologist or colorectal, whoever you're working with.
Okay.
So right, Prosper Physical Therapy.
Okay,
Yes.
so we will put in the show notes Prosper PT so that you all know how to get a hold of Robyn, and we'll put their website and number and all that good stuff in there. And then is there a referral group or something that we can put on as far as a website for
yes.
PT
Yes, so-
folks? Okay.
Yeah. So, so to be able to find pelvic floor
If someone's
therapists.
not in the area.
Yes.
Yeah.
The American Physical Therapy Association, Academy of Pelvic Health, and I'll give you the link if you want to put that
Yeah.
up. They do have a pelvic health provider finder.
Oh, good. That's what we're looking
So
for.
you put in your location, your zip code, what kind of driving range you want, and it will show up different providers in your area.
Perfect.
Yeah.
That's so
Absolutely.
great. Robyn, I cannot thank you enough.
Yes.
This has been amazing.
Thank you for having me.
This is just a joy. So everybody, thank you. And if you have questions, again, we'll put everything in the show notes. If you still have questions, you can email me. I can try to help you get the stuff, but we will get you what you need so that you have a happy pelvic floor. Thank you for listening and asking the question, hey Heather, what about? I hope we inspired you to create a lifestyle for longevity. You deserve it. If something sparked a shift for you today, don't keep it to yourself. Pass it to a friend. Leave us a review to help others find us. Be sure to hit that follow button so you never miss a moment of real talk and real transformation. Ready to start your wellness journey? Visit theexquisitehouse.com to join us in the studio or learn more about The Plan, our signature program for nutrition, movement, and midlife transformation. And remember, keep asking questions. I'll be here with answers.